here at KU, and so she did a lot of research on perinatal depression, and it's definitely a huge area of interest for her, so we're really fortunate to have her today. And so before I turn it over to Heather, I'm just going to launch a couple of quick polls, and so several of you will recognize these polls if you have participated before. So this just gives us an idea, and Dr. Rasmussen, an idea of who is in our audience today as far as your profession. So we'll give you a chance to vote and then share those results in just one moment. Okay, it looks like we have a few of you who haven't voted yet. If you could vote real quickly, we'll get this poll closed. Okay, so I am going to share the results, so you should be able to see the results on your screen. So Heather, I wanted to share with you that 8% of our attendees today are in health or public health, 15% are early childhood mental health professionals, 23% are early childhood educators or care providers, 15% are parent educators, and 38% are other. So for those of you who are other, if you would like to type into the box what your profession is, that would be great. And then we're going to do one more quick poll just to let Dr. Rasmussen know if those of you who are on the webinar today have dealt with families impacted by perinatal depression. So I'll give you just a moment to vote.
Chrissy, while we're voting, I just wanted to mention that this webinar was really scheduled as a direct result of feedback we received last year that folks wanted more information on this topic, so we particularly hope that it's helpful.
Great, thanks Rebecca. Okay, it looks like most of you have had a chance to vote, so I'm going to go ahead and close the poll and share the results. So 77% of you have dealt with families who have been impacted by perinatal depression, and 23% of you are not sure that maybe you have dealt with families who have been impacted. So I hope that information is helpful to Dr. Rasmussen, and I am going to go ahead and turn the floor over to her, so just bear with us while we switch screens on the webinar momentarily, and Heather can pull up her presentation.
All right. It should be showing now.
Yes.
I move that out of the way. All right. Well, I want to thank you for having me today. Along with Children's Mental Health Awareness Month, it is also Maternal Depression Awareness Month. So it's a great and timely topic, and it's all about encouraging moms to speak up when they're down. And I was telling Christy before the webinar started that I am suffering from horrible spring allergies. So I've got 2 huge glasses of water sitting next to me, but I tend to have these coughing fits every once in a while, so I'm going to pull the phone away from myself every once in a while. So if you hear a little bit of silence and hacking in the background, it's just me. I'll be back. But again, I appreciate you having me. I think this is an important and timely topic. And bear with me here. My computer does not seem to be wanting to run. There we go. All right. So what I'm going to do today is I'm going to go over some definitions very briefly, just so that we can all get on the same page, because there's a lot of terms that are used in the literature that maybe we don't use in our everyday language, and so they can be kind of confusing. So I'll just go over those really quickly for all of you, just in case you haven't heard those terms or you're not used to using those terms. Then I'm going to go over the different types of perinatal mood disorders, because there's more to it than just postpartum depression that women can experience after they've gone through childbirth. And so I just want to make everybody aware of those different disorders so that if you see it, you'll kind of know what you're seeing. I want to talk about the importance of screening, because we have a lot of women who are being missed. There is even a campaign, I think it's in Iowa, that's called Looks Can Be Deceiving. And it's because women are really good about hiding different mood disorders, particularly postpartum depression, because of the stigma that's associated with having a mood disorder after having this wonderful event happen in your life, such as postpartum depression. Those of you who voted that you weren't sure that whether or not you've met with women who are experiencing perinatal depression or these other disorders, that is perfectly okay, because again, a lot of women are really good at hiding this kind of thing. I'm going to briefly talk about evidence-based treatments for postpartum depression in particular, and then talk about how we can help. And along the way, I'm going to just read a few excerpts from women who have experienced some of these disorders, just to give you an idea of what a woman might be going through or saying when experiencing these different disorders. All right, so on to the vocabulary. There are lots of different terms, as I mentioned, in the literature and that healthcare providers talk about, but basically this antenatal means during pregnancy, so things that are going on during pregnancy, and postpartum is after pregnancy. And perinatal covers the time during pregnancy in the first year postpartum. Those of you who are mothers may already know that, may have that lingo. All right. So these are the mood disorders or other disorders that I'm going to go through this morning, just to give you a brief overview. Again, just to raise awareness that there's more than postpartum depression that a woman can experience after childbirth. And a lot of times it just gets lumped in with postpartum depression when it's actually not postpartum depression. And the treatments are different for the different disorders. So it's important that we understand these things and get them into the right treatment. Okay. So talking about depression during pregnancy, we have prevalence rates of 10 to 20% of women experience depression during pregnancy. We know that among high-risk mothers, such as teenage mothers, folks who are underserved or in minority populations, the prevalence is even higher. I just saw a statistic this morning that Latina moms have a 30% rate of depression during pregnancy. Unfortunately, the symptoms of depression can be and are often dismissed, and that's because the symptoms are a lot of times confused with the expectations of pregnancy. Healthcare providers just tend to brush them off like, oh, this is just a nervous new mom, that kind of thing, because, moms don't know what to expect a lot of times with their pregnancy, so they may also dismiss the symptoms as just being part of a normal pregnancy. They also don't want the providers thinking that they're bad mothers. Excuse me. And this theme of having people think you're a bad mother will come up again and again and again, and it really is a barrier for women to seeking and receiving treatment. But screening is very, very important because depression is associated with all sorts of adverse events in the baby, including low birth weight, premature delivery, and fetal programming. And fetal programming just means the alterations in the stress response and temperament in the infant. So we can be, affecting the infant's temperament with maternal depression. So again, it's very important that we screen and detect and treat these mothers. So many of you, I'm sure all of you, have heard of the baby blues. There are main differences, though, between the baby blues and major depression. So I just wanted to go over these briefly because most women will experience the baby blues during the immediate postpartum period. It's very normal. With the baby blues, you've got this kind of mood instability. Mom may be happy one minute and teary the next, whereas with major depression, the mood is mostly down. Mom is feeling gloomy, maybe hopeless. With the baby blues, mom's self-esteem is relatively unchanged. Obviously, her body's not back to normal and that kind of thing. So there's some maybe some expectations there that were violated. Why can't I get back into my clothes already and that kind of thing. But whereas with the mom with major depression, you're likely to see low self-esteem. If she's talking about it, you might see guilt more so than the typical mommy guilt. just guilt about everything. A big one with the baby blues is that moms can fall asleep, and they can go back to sleep after the baby wakes them up and they feed the baby or they change the baby. Whereas with major depression, insomnia is a symptom of all mood disorders. So mom typically has trouble falling asleep, and she may have problems going back to sleep. And so when we tell moms, well, you just need to get some sleep, well, the mom knows that, and it's just making her worry even more. I mean, she's probably staying up in the middle of the night ruminating, I need to get sleep, this is going to get worse, worrying about the baby, all of these thoughts going through her head. She's a terrible mom, you know, so on and so forth, and she can't sleep. So that's a symptom of major depression. With the baby blues, as a new mom, you tire easily, but you get rested after you take a nap or something like that. You feel better. Whereas with major depression, it's fatigue. Rest does not help. They're feeling fatigued all the time. They can't seem to get refreshed. Baby blues, they can still feel pleasure. They can still feel joy, happiness at this time, even though they're tired. And maybe feeling physical pain, whereas with major depression, it's the same with any major depression. There's a lack of joy or interest or pleasure in things that they used to find pleasurable. With the baby blues, no major changes in their appetite, whereas with major depression, appetite may decrease, and in fact, we may see significant weight loss during that period. So the baby blues, as I said, affects most mothers, 80% of mothers. It usually peaks starting the 4th day after delivery, and the symptoms can last for up to 3 weeks after delivery. And again, you see that mood instability, the weepiness, sadness, there's anxiety over this new role and responsibility, the foggy mom brain, that lack of concentration. It probably has to do with, you know, not getting sleep and that kind of thing, and taking care of this new baby with all of the equipment and things that come along with them. And feelings of dependency. Again, your role is changed as a mother and with your husband or your partner, and all of these things in your life have changed. And how are you going to go back to work if you're a working mom? So all of this stuff is going on. And part of it has to do with, obviously, the rapid hormonal changes after birth. Part of it has to do with the physical and emotional stress of birthing. A lot of moms are going through physical discomfort for various reasons, depending on what type of birth she had, vaginal birth, there was major tearing, or a C-section, particularly one that she wasn't expecting to have. So all those kinds of things play a role as well. There can be an emotional letdown after pregnancy and birth. There's a lot of anticipation up to the birth, showers, and all of this kind of stuff, and then it happens, and you have this emotional letdown. The baby blues can also be caused by this anxiety about the increased responsibilities that you have as a parent. It can be exacerbated by the sleep deprivation, as I mentioned, and can be exacerbated by disappointments, including maybe the birth didn't go how mom planned it or wanted it to go, and maybe the partner's not being as supportive as mom had hoped, or not in the way she wanted, and maybe nursing isn't going well. If she's a nursing mom, maybe it isn't going well at all. So those kinds of things can increase the baby blues, and some of them can be a risk factor for postpartum depression. Sorry, taking a drink there. So you'll see on this slide that I'm now talking about major depression and anxiety, and I put those together because the comorbidity rate in the postpartum period is so high. 76% of women had comorbid diagnoses for depression and anxiety disorders, so I put them together. It occurs in 15 to 20% of new mothers. That's a really high rate. And if you think about other disorders that we routinely screen for, they have much less of a prevalence rate, but we routinely screen for those, but we don't for postpartum depression, which I think we should be because it's at such a high rate. It can happen anytime in the first year, but the highest risk for postpartum depression is in the first 3 months postpartum. And we see these typical symptoms of depression. So most women are going to have worry or anxiety in the postpartum period. This is excessive worry or anxiety. It's affecting her functioning. Sometimes, particularly partners will report, I didn't know it was postpartum depression because she just had a short temper and she was angry all the time. She was just irritable. Well, that can also be postpartum depression. It doesn't necessarily always have to show up as sad mood, which it can, though, along with guilt and phobias. You may see hopelessness. There could be, again, the sleep problems and fatigue, physical symptoms or complaints beyond what you would expect in the postpartum period. Mom can report, or you can see a discomfort around baby, or she may report not feeling anything toward the baby, not having any feelings toward the baby, and ambivalence, or even anger toward the baby. You might see a loss of focus and concentration. She may be missing appointments, that kind of thing. And again, there's that loss of interest or pleasure in things that she used to enjoy, and then the appetite changes. I want to point out here that there is nothing in here about psychosis. And I point that out here because the media has, unfortunately, a history of saying postpartum depression when they're referring to women such as Andrea Yates and the tragedy of the woman, she drowned her children. But she didn't have postpartum depression. And there are even national organizations like the National Organization for Women originally misidentified her as having postpartum depression. But she suffered from a different disorder, and that's postpartum psychosis, which is a different diagnosis, and I'll go over that in a moment. But these kinds of incidences, unfortunately, have led women with postpartum depression then to hide their symptoms because there's increased stigma. People associated with postpartum depression with women kill your children. And in fact, the rates of infanticide with psychosis are not as high as one would expect given what the media tells us. But anyway, there is still this increased stigma around postpartum depression. We saw it and played out in the media with the Brooke Shields, Tom Cruise thing when Brooke Shields came out that she had postpartum depression. But I just read something the other day about another celebrity, Gwyneth Paltrow, when she experienced postpartum depression with her son, her second child. She noted that she felt like a zombie. She couldn't access her emotions or her heart for her child, and she felt like a terrible mother and a terrible person. There comes that theme up again. And really the hardest part, and this is another thing, was acknowledging that she had a problem. A lot of women are going to say, it's okay, I'm getting through this, it's okay, because admitting it makes one feel like a failure. As far as the prognosis for postpartum depression, the good news is that most of it resolves spontaneously within 3 to 6 months, but there are about 1 in 4 mothers who are still depressed at their child's first birthday. I will point out that suicide remains a leading cause of maternal deaths in the first year postpartum, although the postpartum suicide rate is lower than the rate in age-matched non-postpartum women. So just because the woman's postpartum doesn't mean she's at this exponentially higher rate of killing herself. So I'm going to get that myth out of the way. While it's important to consider, it doesn't necessarily go hand in hand. While I don't have time to go over it today, I do want to just point out that dads get postpartum depression too. In fact, research has found about 10% of dads get postpartum depression, and that could be a totally its own presentation. But I did want to point that out for you to not forget about the dads, because there are adverse effects with the children with dads who are depressed too. So we don't want to forget about that. With mom's postpartum depression, we see negative effects in the infant, including reduced likelihood of secure attachment, deficits in maternal-child interactions, and other impaired cognitive and emotional development in the child. So I will go over those things in a bit. I wanted to put this quote up because it's another good quote regarding the stigma that surrounds postpartum depression, that even though there's a very high prevalence of it, and we screen and for these other diagnoses that have lower prevalence rates routinely, we still somehow see depression as not a real illness. So this woman said, when I had cancer, I thought that that was the worst experience I could ever have, but I was wrong, this is. With cancer, I allowed myself to ask for help and expected to be depressed. My friends rallied around me, bringing me meals, cleaning my house, and giving me emotional support. Now, during postpartum depression, I feel guilty asking for help and ashamed of my depression. Everyone expects me to feel happy, and they don't accept that this illness is just as real as cancer. So a woman with perinatal depression often feels like she's losing it. It's hard to predict a lot of times how she'll feel at any given moment. When she gets up in the morning, she may be gripped with anxiety. At 10 o'clock, maybe she feels almost okay, and then 10:30, she's depressed again. And the interesting thing is women who have experienced depression and postpartum depression say that postpartum depression feels very different to them and usually much worse than depressions at other times in their lives. Okay, on to another disorder, obsessive-compulsive disorder. This affects about 3 to 5% of mothers, and the symptoms include your typical OCD symptoms with intrusive, repetitive, persistent thoughts or mental pictures. These are thoughts about hurting the baby, and people hear this, and again, there's the stigma attached with the infanticide and hurting the baby. The thing with the mom with the OCD is she has a tremendous sense of horror and disgust about these thoughts, and she wants to do everything she can not to hurt her baby. So it may be accompanied by behaviors to reduce the anxiety or to make sure she's not going to hurt her baby, like the counting, the checking, the cleaning. For example, a mom may wash her baby repeatedly to stave off germs to the point where the baby develops sores. Mom may refuse to hold the baby because she's afraid of dropping the baby. Mom may make dad hide all the knives in the kitchen because she has visions of herself stabbing the baby, and she's horrified of these. Mom won't carry a baby out to the balcony because she's afraid she's going to throw the baby over the balcony. So again, this is obsessive-compulsive disorder. It's not the same as psychosis. Mom is going to do everything she can not to have this happen. It's intrusive thoughts. I'm going to read an excerpt from a woman who suffered from obsessive-compulsive disorder just to give you a flavor of what it's like. Each time I went near the balcony, I would clutch my baby tightly until I was in a room with the door closed. Only then did I know he was safe one more time for me dropping him over. The bloody scenes I would envision horrified me. Passing the steak knife in the kitchen triggered images of my stabbing the baby, so I asked my husband to hide the knives. I never bathed my baby alone since I was afraid I might drown him. Although I didn't think I would ever really hurt my baby son, I never trusted myself alone with him. I was terrified I would snap and actually carry out one of these scary thoughts. If my baby got sick, it would be all my fault, so I would clean and clean to make sure there were no germs. Although I had always been more careful than other people, now I would check the locks on the windows and doors many times a day. There are great treatments for obsessive-compulsive disorder, but they really have to be folks who are really well-versed and trained in certain types of psychotherapy. And I'm not affiliated with these people at all, but they are really great at this, and they will treat women who are in the postpartum period suffering from postpartum OCD, and that's the Kansas City Center for Anxiety Treatment. And they're one of the best places in our multi-state area because they offer different treatment protocols. They offer intensive treatment like multiple times a week. They offer telemedicine for people at a distance, and they will go into the home and the community based on what the the person needs to resolve their anxiety disorder. So they are very specialized in that area, and they also conduct research on their protocols, so they just really know what they're doing, and they can be very helpful for someone who's suffering from this type of disorder. Panic disorder occurs a little bit more often. It's in 10% of postpartum women, and these are it's more than what people would call an anxiety attack. This is where someone's having extreme shortness of breath, like they cannot catch their breath. Maybe they have chest pain to where they think they're having a heart attack. Many people go to the emergency room thinking they're having a heart attack. There may be extreme dizziness. People report feeling hot or cold flashes, trembling, heartbeat going to beat right out of their chest, feeling so restless or agitated that they just want to crawl out of their skin. And while this is going on, they're feeling like either I'm going crazy, I'm going to die, I'm losing control, and there are no identifiable triggers. In fact, some women report having panic attacks awaken them in the middle of the night. Other women report having panic attacks while breastfeeding. So you can see how that would be especially problematic for a mom, already feeling like a failure and feeling anxious. And here's this supposed to be blissful motherhood experience, and she has a panic attack while she's trying to nurse and feed her child. So again, something to consider during the postpartum period. PTSD, it occurs in up to 6% of women. Again, similar PTSD symptoms, extreme anxiety, probably having recurrent nightmares and reliving of past events. Feelings of detachment is where women may be feeling like they're floating above their body, watching the scenes going on below them. And the risk factors, of course, are past traumatic events. Could be child abuse in their childhood, or it could even be a traumatic childbirth. And childbirth traumas can include things like a prolapsed cord, having an unplanned C-section, use of vacuum extraction or forceps during delivery, having their baby go to the NICU, anytime they're feeling extremely powerless, and having a lack of support and reassurance during delivery, that can trigger a post-traumatic stress response. Okay, bipolar disorder. We really don't know the rates of bipolar disorder because we think it's because postpartum depression is often thought of just being postpartum depression, but some of those cases are probably a bipolar disorder that hasn't been diagnosed as such, just because the manic phase hasn't manifested itself during the postpartum period. So we're not noticing that, and a lot of times people don't notice what we call the hypomania. So that's just, energy and feeling good and that kind of thing. So not the grandiose, inflated self-esteem, extremely manic type of phase that you would see with the bipolar 1. But it's important for a clinician who knows the mood disorders and is a very good diagnostician to really figure out what's going on, because the treatment is different for depression and bipolar disorder. And speaking of bipolar disorder, we'll talk about postpartum psychosis now. Fortunately, it's very rare. It occurs in 1 to 2 women per 1,000. And the onset is usually within 2 to 3 days postpartum, but it can occur anytime in the first month after birth. And the symptoms are the woman will have very disorganized behavior, and it's a complete change from previous functioning. The woman probably is going to have delusions of strange beliefs. So they probably are going to be talking things like, she didn't have a baby. She didn't just have a baby. Needing to kill the baby because the baby is Satan, or something like this. Or God told her this, she needed to sacrifice the baby. Or delusions about she had the baby but the infant died. So just really strange delusions and beliefs. Extremely irritable and hyperactive, can have any type of hallucination. So, excuse me, that would be, they could be smelling things that aren't there, they could be seeing things that aren't there, hearing things or feeling things, bugs crawling on them, whatever, that aren't there. Extreme paranoia and suspiciousness. They can also be experiencing mania, so really inflated self-esteem, lots of energy, don't need sleep, stay up for multiple nights in a row. And the risk factors for this are a personal or family history of psychosis, schizophrenia, or bipolar disorder. And there are researchers who believe strongly that this is a variant of bipolar disorder. But there's kind of a difference, too, because there's almost this delirious quality of the psychotic episodes that are different than what someone might have a psychotic episode that when they aren't in the postpartum period. I will point out that while we think that this is a very serious condition, this is a psychiatric emergency. If you encounter a woman who is experiencing this is a time for hospitalization. The woman needs to be treated right away because there is a risk to her and her baby. The risk is not 100%, of course. It's 5% for suicide and 4% for infanticide, but obviously that risk is too high at all. So we need to make sure we're treating that as a psychiatric emergency. And this is what the tragic case of Andrea Yates, she had postpartum psychosis. And I just want to read you a quick excerpt from a man whose wife had postpartum psychosis. My wife, Gloria, had a great pregnancy and a long labor. We were thrilled to have our first child, a son, but within days of his birth, my wife began to withdraw into her own world. She became less and less communicative, and she became more and more confused and suspicious. I almost had to carry her into the therapist's office. By that time, she could hardly speak or answer questions, nor write her names on the forms her therapist gave us. I was told to take her to the hospital immediately. When we arrived at the hospital, she became fearful and violent, so there's that suspiciousness. She ended up in restraints. Fortunately, she responded pretty quickly to the antipsychotic meds and was able to come home after about a week. She continued to improve, and when she was back to herself again, she slowly weaned off all of the medications. We'd always wanted 2 kids, so we consulted with our therapist and psychiatrist. With careful planning, we now have our second child with a very different story to tell. So that's just to note that it's not hopeless, certainly at all, for the woman. If we can identify these things and take preventive measures, they can have a lot better outcomes than some have had. So back to perinatal depression, what really is the focus of this presentation. Why should we focus on perinatal depression? And that's because the prevalence rates are so high. 500,000 women in the United States each year are at risk for postpartum depression. For those in poverty, it's even higher. And the risks for untreated perinatal depression are large. We see obstetric complications, including low birth weight and premature birth. We see consequences for fetal programming, and again, that's the alterations in the stress response in the baby and the temperament of the baby. We don't want, to have moms who are already depressed, and then you have a baby that's crying all the time. That's not helpful, obviously, for anyone, let alone a mom who's depressed. And we see emotional, cognitive, and behavioral adverse effects on infants, which I'll talk about now. Before I talk about that, I just want to point out that only 1 in 5 women in prenatal care who met criteria for any psychiatric diagnosis received mental health treatment. Only 1 in 5. And then we have 20% of women who screened positive for depression. So of those we screened, which we don't screen everybody, but only 13% received treatment for depression. In low-income mothers, it's even higher. Only 30% of mothers who had severe depression reported getting help. So again, there's this need to screen. So maternal depression is linked to children having increased cortisol levels at preschool age, and you're thinking, okay, so what? Well, cortisol is linked to internalizing problems in children, including anxiety problems, feeling very socially wary, withdrawal. We also see negative relationships in early childhood and reduced language abilities. We see that maternal and depression and anxiety is associated with a stronger risk of child behavior problems than the other 4 risks track, including mom smoking, drinking, emotional and physical domestic violence. In school-age children, we see more hyperactivity and distractibility. At 11 years of age, this study found that children of moms who were depressed at 3 months postpartum had a lower IQ, were exhibiting more violence. The girls tended to have more aggressive behaviors, and boys were exhibiting greater behavior problems overall. In children and adolescents, we still see the effects of maternal depression. We see these kids having difficulty making and sustaining friendships. They have a lower ability to show affection. They have less control of emotion during stress, lower self-esteem, and in general, more behavior disorders overall. It lasts into adulthood. These, we see the adults having a greater likelihood to develop depression and anxiety. They're 5 times more likely to have a substance abuse problem, and 78% suffer from more than 1 psychiatric disorder. So you can see there are a lot of reasons to intervene when mom has a mood disorder. We know more about maternal depression than other disorders, but again, there's a stigma to women seeking help. Research reviews have found that again and again, women do not proactively seek out help for maternal mood disorders. They don't seek out help because they don't want to be seen as a bad mother. We also have these myths in our society. One of them is this myth of immediate bonding with an infant. If a mom doesn't feel an immediate attachment like she sees on like the baby stories on whatever Lifetime or whatever those shows are, she's a bad mom, she feels like. We also have this motherhood bliss myth. Again, those shows, we see this blissful right after birth on the movies and that kind of thing with the 2-minute birth, which I wish I would have had a 2-minute birth. But if she doesn't, then she's the bad mom. Something is wrong with her. And again, with mom, when she experiences difficulties with something that's supposed to be natural, such as breastfeeding, again, she might think, what is wrong with me? Why am I failing at this? I'm a terrible mom. I'm ashamed. And so when these things don't happen, mom can feel discouraged. She can feel like a failure as a mom and may not seek help because of shame. Some of the thoughts and feelings of depressed moms, no one has ever felt as bad as I do. I'm all alone. No one understands. I'm a failure. I'll never be myself again. I've made a terrible mistake. I'm losing it. They think I'm a horrible mother for admitting I'm feeling this way. And the big one, they'll take my baby away. And mom may not readily admit these to anyone without some probing or screening. And one of the ways to probe or screen is to really bracket and normalize a range of answers for mom, which I'll give an example a little bit later on in the presentation of how to do that, which some of you probably already do anyway, but just to reiterate. There are also myths about nursing and bonding with baby, as I mentioned. You know, I can't be a good mom unless I nurse my baby. My baby won't bond if I don't nurse. And I put these myths up because I think many of us, if not all of us, would agree that breastfeeding is best for the baby, but it doesn't come easy for every mom. And there are moms out there who have tried to nurse their babies and have not been successful, and so they feel like failures, and there's a lot of judgment around this among mothers. There's just a time cover yesterday, I don't know if you all saw, about extended breastfeeding and the mommy wars, so it continues in our culture. And unfortunately, there's a subset of mothers who experience loss based on the inability to breastfeed their baby. So they go through a loss and grief process. And there are internet support groups and listservs regarding this. Along with this, as I mentioned earlier, mothers who have births that they weren't expecting, like unplanned C-sections, which the rate is increasing to approximately 30% of births are now C-sections. They're experiencing loss of their expected birth and labor and delivery, feel like their bodies have failed them. So again, these women can be also at risk for depression in the postpartum period. So screening for postpartum depression. Now that we can see the importance of needing to screen, because a mother may look fine and happy to us, because Many of them hide what they're feeling. Again, there's that there's the Iowa campaign for postpartum depression awareness, and it's I can't remember. I think it's You Can't Tell by Looking is a good tool that tells you that women often hide their depression because of the stigma. And we also know from studies that even people who are supposed to be trained in this or have some training in it, in primary care settings, many women that were missed by the primary care folks were identified using the standard screening tools such as the EPDS, the Edinburgh Postpartum Depression Scale. It's a quick scale. It's 10 items. It's widely available and can be used without permission. It takes about 5 minutes. It can be used to screen for depression during pregnancy, for depression in fathers, for depression in adoptive parents, as well as mothers and fathers of toddlers. And so it's it's been translated into many, many languages. It's been used cross-culturally. So it's a great way to screen for depression. It's a good tool also because it does not include somatic or physical symptoms like other depression scales do, because obviously women in the postpartum period are going to have physical symptoms that they're experiencing that could mess up your screening. All right, so here's some warning signs that a woman may be experiencing postpartum depression or another diagnosis. She may be having missed appointments, excessive worrying about herself or the baby even after you've tried to calm her fears, looking unusually tired. Obviously, women in the postpartum period usually look tired. That significant weight gain or loss. Evading questions about her own well-being is a big one that you should be have a red flag for. Excessive concern about the baby despite the reassurance. So you're telling her that the baby's eating sufficiently, gaining weight okay, and she's still extremely worried and talking about it. Expressing a lack of partner support or saying that the baby doesn't like her, she's not a good mother. Those are all kind of warning signs to look out for. So again, we want to be normalized and non-judgmental, which I'm sure you all are. But one way to ask these bracketed questions that give her a range of answers, and this comes from motivational interviewing, the substance abuse literature, where you would ask somebody some people have 0 beers and some people have 30 beers in a day. Where would you say you fall? So you give them this range of answers so there's not so much stigma attached when they tell you they have 25 beers or whatever. So you ask, some moms feel overwhelmed, stressed, or worried after having a baby. How are you doing? How are you feeling about being a mom? Asking her how she's sleeping and asking her, can she sleep at night when everyone else is asleep? So these are not, are you feeling depressed? Because a lot of women are going to say no. So again, trying to couch it in different terms. Some moms say they feel like they're not their usual selves. Do you usually feel like yourself? Women with postpartum disorders often report not feeling like their usual selves, or they even have a different personality, it feels like. So again, this gives you good information. Another one is some moms feel like they have no feelings toward their baby, or they even have feelings of anger toward the baby. How are you feeling toward your baby? Because ambivalence and anger are 2 examples of feelings that may indicate postpartum depression. I know you cannot read this. I just put this up there, though, so that hopefully you would go to the website and look this up. I give the website in just a few minutes. But this is called the Care Pathways Algorithm, and it includes a PDF of instructions to go along with the algorithm, but it's kind of a decision tree that can go along with the Edinburgh scale that gives you an idea of should you refer to counseling, should she get immediate treatment, can you wait a little bit, that kind of thing. But it's a great resource that can give you a little bit more information and help when screening for postpartum depression. All right, on to treatments for postpartum depression. The good news is that we have some great treatments, and they're effective. The 2 gold standard talk therapies are interpersonal psychotherapy, or IPT, and cognitive behavioral therapy, good old CBT. And for example, the studies have shown for the IPT a decrease in depression and improved relationships and postpartum adjustment compared to the control group. And I worked with Dr. O'Hara at the University of Iowa, and he's really big in IPT with postpartum depression, so I had to give a plug for him. We have a meta-analysis of psychotherapies for postpartum depression, and a meta-analysis is basically where the researcher takes a bunch of different other studies and they statistically combine them. So we have this effect size for all of these studies on this particular topic in an area, and they found a large effect, 0.6, for the effectiveness of psychotherapies. We know that therapy reduces symptoms of depression. A lot of times, unfortunately, we don't have the providers to provide the treatments for postpartum depression, and or the women don't have the time or the money to access these treatments. So there are barriers there. On to the psychotropic medication. Again, antidepressants are effective. We know that. Some are considered safer for breastfeeding moms and infants because they're not detected in the infant after nursing, but there have been no controlled studies evaluating the safety of the psychotropic medication in breastfeeding women. So this is a case where you need to have a psychiatrist or other provider who's very familiar about psychotropic, the antidepressants, usually the SSRIs are effective, and know about breastfeeding moms to be able to evaluate the risks and benefits for that particular patient. The barrier here is that 50% of mothers will not take medication. So we have treatment barriers here and treatment burden. So once we actually screen the moms, then figuring out how to get them good treatment is the next barrier we face. So, we screen moms, and 50% of them aren't going to take meds, or maybe some of them want to go to a talk therapy. Maybe the therapist isn't available, or maybe their provider is too far away. Maybe there's a stigma of going to mental health provider's office. So one way to reduce that would be to co-locate mental health perinatal care so that mom can get kind of a one-stop shop there. We also have issues of moms feeling like they just don't have a lot of time. An infant takes up so much time, this little being. You can't imagine how much time they take up. There could be issues of not having the money for these other treatments. Maybe someone tells mom, just find a babysitter and go, to therapy or whatever. Well, maybe mom feels extremely guilty and will not leave baby with a babysitter, but then thinks, I can take the baby with me, but if you've ever had an infant, you know how hard it is to get anywhere with an infant, even if you aren't depressed. And so why not just stay home and forget about it? It just seems too overwhelming, or maybe they can't afford a babysitter. So there are all these barriers going on for once we screen mom. So along with, our in-home nursing care and those kinds of things, and then in-home visitors and those kinds of things, the researchers are really looking at incorporating evidence-based interventions into new, more accessible formats. And this research is going on right now, so we don't know how effective they are, but they're looking at online treatments. They're looking at these interesting self-care kits that are based on cognitive behavioral therapies. There are different modules that mom can take home that have a low literacy level, so anyone can access it. And there are videos and different things. So there's lots and lots of different treatments out there that are being studied. I want to give a plug for some resources. These are local and national. The Postpartum Resource Center of Kansas, they provide phone support in Kansas and Missouri. I've included the phone number there. They also have in-person support groups in Lawrence and Prairie Village. They also have provider resources on their website. The National Suicide Prevention Hotline for Postpartum Depression is 1-800-PPD-MOMS. Postpartum Support International is a great organization. They have lots of provider resources, as well as resources for support people and moms. They also hold a monthly free call forum with an expert where you can call in and talk to an expert. mededppd.org, I would suggest all of you go to this. They have two different websites. One is for mothers and support people. The other side is for professionals. And they have so many materials and online training for professionals. It's all evidence-based. These are the top researchers in the field. They have the Edinburgh up there. They've got that care pathways algorithm, just tons and tons and tons of stuff. I would really highly recommend that people go check it out. They have continuing medical education, all sorts of stuff. Postpartum dads, don't want to forget about them. They provide resources and support for partners. There are awareness campaigns out there. This Road and Creighton Foundation is one of them. And I also included a blog called Postpartum Progress. And this is created by a postpartum depression survivor. It's considered one of the top mom blogs out there. She provides lots of information, resources, support for her warrior moms, as she calls them. She, along with some other warrior moms, hold weekly chats on Twitter so that moms who need support can get on and have a weekly chat on Twitter if they have access to the internet, which again can be a barrier. But we know from research that peer-to-peer support can be effective for some mothers. I wanted to include this because I know that some mothers have found this extremely invaluable to have that resource when other ones aren't available. Other ways you can help, obviously offering her non-judgmental support. You don't want to offer advice right off the bat because it can increase her depression and anxiety and make her believe she is doing everything wrong. You do want to let her know she's a good mom for trying to get help, for taking care of herself, and she's doing the best that she can at this point. We want to remember that depression really interferes with the person's ability to think clearly and believe what you're saying, so she'll need lots of support and you'll need to repeat these messages to her many, many times. You want to let her know that many women who have had babies have had feelings like those she's been describing. It's not her fault, and that she can change it. There are treatments that are available that work for postpartum depression. Give her some hope that she'll get better with the right treatment. You'll also, with postpartum depression in particular, trust her that she is the expert on her baby and help her trust those instincts. And again, just let her know that it's a very treatable condition, and with the right treatment she can get better. People often ask, what should I say and what not to say? Well, here's just a little quick rule of thumb, because you hear people saying these things a lot. Join a new mom's group, just exercise, just sleep when the baby sleeps, do something nice for yourself. These are all wonderful things to say, and they're well meant, well-meaning. But for a mom with depression, these kinds of things can come across as insensitive and feeling overwhelmed. Exercise. When the heck am I going to find any time to exercise? Sleep when the baby sleeps? I know I need to sleep when the baby sleeps. I can't. So they aren't helpful. Instead, just use those basic counseling skills. Let her know it's treatable. You will get well. These feelings are quite common. Normalize it for her. Give her some hope. And finally, again, it's important because it's so widespread. Again, 500,000 women in the United States each year are at risk for postpartum depression. It's higher among low-income women and minorities. It can pose serious barriers to healthy development and school readiness in our kids. We know that it's been linked to long-term adverse outcomes. And we know a lot about how to treat it, which is a good thing. But too often, the barrier is getting women to get that appropriate help. So we want to invest the time and energy and support for this generation to promote healthy development for the next. And that's all I had. Is Christy there?
Christy, I believe that your line might be muted.
Okay. I was talking, and I guess I had myself muted, so I apologize for that. Yeah, where did she go? No, I was actually talking. So for those of you in the audience, if you have any quick questions, we are about out of time, but if you could type them in the question or chat box, or if you raise your hand, we can call on you. Heather, we did have a question that came in that I was asking you when I was on mute, and it
Oh,
is postpartum depression more common with a first child, or does it make a difference?
it can occur with any pregnancy. I mean, a good example is Gwyneth Paltrow with Blissful with her first baby, as she says, I think Apple, and then with her second baby, she had the postpartum depression. So it can occur with any pregnancy. We do know, of course, that if you've had depression before, you're at much greater risk of having postpartum depression. So those moms who have been depressed before, we really want to wrap support around them because they're more likely to have difficulties after having a baby.
Okay, great. And one other question that came in, or one thing we wanted to share with you, is that our partners at the American Academy of Pediatrics Kansas chapter are wanting to get pediatricians across the state to screen using the Edinburgh. And the question is it appropriate for a home visitor or a preschool staff person to use the Edinburgh?
Oh, yeah. I mean, there's the mededpdpd.org. Again, you can go on and learn how to use it. They've got that care pathways algorithm, and it's just a screening measure. It's not a diagnostic measure, so you don't have to, be licensed or whatever to diagnose postpartum depression. You're screening to see if they need to go to a mental health professional or another provider. So absolutely, absolutely. The more, and in fact, there are lots of research projects going on right now about training non-mental health providers, even in giving these evidence-based treatments, because again, we want to get it out to the community as best we can. So mental
Great.
health providers are limited. So
Right. Okay, and a couple more quick questions. One is, if peer support is important, why would it be inappropriate to suggest a mom's group?
Well, you don't want to suggest that right away. You want to establish, you don't want it to seem like you're brushing the mom off, in other words, just saying, well, why don't you just join a mom group? And you have to be careful because some mom groups are more appropriate, of course, than others. And not every type of treatment is going to work for every mom. So some moms would do, with maybe a mild depression, would do very well in a peer support group, and that would be great and enough. But other moms, it may just make her feel worse if she has a more severe depression. They may not be the appropriate thing for her. And so again, we just want to be careful and have her evaluated by a professional before we suggest different treatments.
Okay, great. Thanks so much. Well, I think that's all the time we have for today. We really appreciate your time today and
Sure.
the information. And so we will be posting the resources that Heather has mentioned today, as well as a copy of her handout. So those resources will be available on the KECCS.org website, so please go there. There will also be a copy of the recording available if you want to recommend this presentation to colleagues who weren't able to hear it. So I would like to thank you for participating, Heather. We really appreciate your webinar, and I would like to thank everyone in the audience for participating in National Children's Mental Health Awareness Week. We think we had a great week. It seems like we really got a lot of great information. So take care, everyone, and I hope you have a great weekend. And thanks again, Heather.
Thank you.